Any health-related information on the following show provides general information only. Content presented on any show by any host or guest should not be substituted for a doctor's advice. Always consult your physician before beginning any new diet, exercise, or treatment program.
Welcome to Accelerated Health TV and Radio Show. I'm your host, SaraBanta. I'm a health coach, natural supplement expert, and a busy mom of three. Make sure you hit the subscribe button below so you're notified every week with my new podcast on Mondays and Tuesdays. And if you haven't already, join my free group coaching on Telegram with the link below. There is no downside. I teach you on a daily basis with tips and tools to enhance your health. And you will be a part of a like-minded group to support you on your journey, in addition to truly taking control of your health. The protocols and supplements I discuss are all found at my website, SaraBantaHealth.com. Today, we are talking about a topic that is close to my heart because it affected me. And Dr. Jaime Seeman is here to help us do that. She is a board-certified OBGYN with a background in nutrition, exercise, and health science. She is also a current fellow in integrative medicine and a board-certified ketogenic nutrition specialist. Welcome, Jaime. And she's also a wife and a mom of three little girls. So all of this hormone talk is going to hit her hard soon.
Thank you, Sara. It's so good to be here. Appreciate it.
Well, this is a topic, as we were talking about before we came on, that hit me. I had PCOS and I had a hard time getting pregnant. Never thought I had kids, had to go through the mental preparation of actually adopting, maybe, possibly, who knows. But now I was blessed with three amazing human beings that are now teenagers and a son that is in his 20s. So it's, for all of you listening out there, PCOS is the number one cause of infertility. And it's really actually easy to reverse most of the time. And if I knew back then what I know now, I wouldn't have needed help to get pregnant, and it wouldn't have been a stressor. So I'm super excited to get into this. But why don't we first start, Jaime, and you telling us a little bit about your history and your journey. I mean, you're in the medical field, but it affected you on a personal level and not just in your field.
I think we all kind of live out our passions, based on our experiences and the lens, in which we see the world. And I have a very personal experience with PCOS and infertility. So I work as an OBGYN. So every day I'm in clinic seeing women, everybody from teenage girls all the way to postmenopausal women. I deliver babies, I do surgery, I treat incontinence, sexual dysfunction, and everything in between. But before I went into medicine, I grew up as an athlete. So I played multiple sports. I went on to college, was a collegiate athlete. I played softball at the University of Nebraska. And while I was there, I was pursuing a degree in nutrition and exercise science because there's no, pre-med degree you get to choose, which was kind of unique at the time because most doctors choose biology or chemistry or, some of the basic science. But as long as you take all the prerequisites for the MCAT, you can study anything. So I thought, well, if I don't go to medical school, I'll do something in the, athletics world, nutrition world. And now I'm very thankful that I got that degree because it's very different than a lot of my colleagues. But I was a 3-sport athlete and then a collegiate athlete. But this transition from college into medical school was the first time in my life where I went from being very active. I don't want to say forced, but it was just my life being an athlete. I was working out all the time, lifting weights, and my diet was not great growing up. So God bless my parents. They did the best they could, but I ate a lot of processed foods. And then even when I went to college, when I was at the training table where they feed the athletes, it was kind of eat the rainbow, have some protein, but eat the rainbow. And there was a lot of carbohydrates, a lot of pasta, a lot of, breads. And I was always kind of told, athletes need carbohydrates. You need to fuel, carb up before your competitions and things like that. And so, and then in my nutrition degree, it was very much at the time where fat was vilified. Fat causes heart disease. Saturated fat is really bad for you. Eat low fat diets and, count your calories. So I made this transition into medical school where I suddenly was much more sedentary. I was sitting in the classroom for long periods of time. I was in the library, studying in the coffee shops, and was definitely not moving as much. I was working out a little bit, went through a little stint with P90X. Who remembers that?
Yeah.
But I started to struggle with my weight. And so all I knew was, limit fat, count calories. And I remember there was a point in time where I was keeping a log, and I was literally, while I was studying, I would eat pretzels and goldfish crackers. And I was literally counting my, 50 individual goldfish crackers. And it worked a little bit, but in medical school, my husband and I we wanted to start a family. And I had been on some form of birth control in college and into medical school. And so I came off of birth control and I was not having periods. So I'm not getting these periods. I went to my doctor. She said, well, I don't think you're ovulating. And so months kind of went by. And because of medical training, I specifically wanted to get pregnant sooner rather than later because, I didn't want to extend into graduation and not, have achieved a pregnancy yet. So after about 9 months, my doctor said, well, I think we should start some metformin, which is a common medicine used for diabetic and pre-diabetic patients for insulin resistance. And she said, maybe this, will help. And then we'll add Clomid or clomiphene citrate, which can help patients with PCOS ovulate. So I started the metformin, and I knew from my medical school lectures, what I had been told was that 10% of patients, if a PCOS patient can lose 10% of their body weight, sometimes it will restore ovulation. So on a very calorically restricted diet, I was actually on a family medicine rotation at a very rural hospital, and I was having to eat all my meals at the hospital cafeteria. And I remember I was eating basically salads with cottage cheese on top and a few sunflower seeds. And whether it was voodoo or the caloric restriction or the metformin, I didn't have to pick up the Clomid prescription. I got pregnant that month. And so we had our first daughter in medical school. And then I went on to complete my OBGYN residency and had 2 more babies. But during my pregnancies, I failed my glucose testing. I was diagnosed with hypothyroidism after my first pregnancy and had to go on thyroid replacement. And then fast forward, I was done with training. I'm out in private practice. I'm seeing patients. I'm seeing patients just like myself, struggling with a lot of these same problems. And I had my labs checked, and I had hypothyroidism, but now I had prediabetes, and I was terrified. Here I am as a clinician, a background in nutrition, exercise science, and I'm sitting here with these preventable medical conditions. And at the time, I had stopped lifting weights, and really the only exercise I was doing was I had signed up for a couple half marathons thinking I could lose the baby weight after my pregnancy. So I was doing a lot of running and not a lot of weightlifting. And once again, just trying to control calories. And so I thought, there has to be something better, for our patients. Lifestyle is so important. What am I missing? And so I went back to training. I did an integrative medicine fellowship. And in my personal life, had started to kind of change my diet. I started with Whole30 and paleo, and then eventually transitioned to a very low carb, ketogenic lifestyle. And oh my gosh, things just got so much better. I got off my thyroid meds. I was menstruating very regularly. It was like the lights came back on in my brain. My energy came back. I was sleeping great. I eventually got back into, lifting weights and things like that. But what it did was this personal transformation for me transformed the way that I practice medicine. And, going back into integrative medicine, it armed me with a lot more tools in my toolbox to help my patients. And thankfully, it was early in my career. And so now I've been able to help so many people, that were in my own shoes, not only with PCOS, but, reversing their diabetes and prediabetes, reducing their risk of cardiovascular disease and dementia, all of the things that are most likely to kill us and make our life very miserable. So it's been quite a journey, but I have 3 daughters of my own, like you mentioned. And so this is very near and dear to me because they're coming into an age where I wish I had known all the things that I know now.
I know I school my kids, as you can imagine, on nutrition and health. And now that they're getting into they are into their teenage years. And one of my daughters has the profile that she could be PCOS. The other, like I mentioned before we got on, is more prone to endometriosis. And I can see the blood sugar dysregulation in my one daughter and we're managing it, but it affects her cycles. It affects how painful her periods are every month. And the connection between sugar regulation and prediabetes, insulin resistance, and PCOS is so strong. When I was trying to get pregnant, no doctor told me that at all. And I think I'm older than you, where there was just a prescription for Clomid, and that's what we're going to do. And no one looked at me and actually even said that you can do anything about your PCOS. There was no connection to thyroid. There was no connection to insulin resistance. I have to be super careful with blood sugar. And when ketogenic diet came out, I hopped on right away, and it was amazing, the shift in my body, in my brain, my body, my hormones. And I thought, oh my gosh, I wish I wanted to get pregnant right now, because I know I can without the help of drugs or a doctor. You said something before we came on, and I want to touch on this, that I had mentioned I had PCOS as well. And you said a lot of athletes did. What do you think that connection is? Because most people think of PCOS as someone that's more sedentary, insulin resistant, overweight. What do you think that connection is with athletes?
Well, one of the diagnostic criteria of polycystic ovarian syndrome is hyperandrogenism, which is elevated androgen hormones. Now, I don't want to call them male hormones, because women do make androgens, which are testosterone and DHEA. And in these patients, the elevation of testosterone and DHEA, it's an anabolic hormone. And so it's really good for building lean body mass and for growing the body and body fat. And so sometimes these patients tend to be physically larger, physically stronger. They do have a little more, predisposition to athleticism. And so, I'm thankful in that regard, I guess, if there's any positives out of the whole thing. But it's actually not uncommon amongst collegiate and professional athletes that there's a higher rate of PCOS compared to the baseline population due to the higher androgen levels.
That does make sense. And, I love my testosterone because it feels good. It gets me out of bed. It's the motivation hormone, and builds that awesome lean muscle. And, but then there's also the downside. Well,
Yep.
Can you describe what is PCOS? Here we are talking about it. It's the number one cause of infertility. What is PCOS?
So PCOS, polycystic ovarian syndrome, I think it's such a poorly named, pathology, because a lot of people think it just involves cysts on the ovaries. And to just dispel a little bit of myth, the ovaries' job is to make cysts. So if you've been in an emergency room or a doctor's office and you've had a gynecology ultrasound where they've looked at your ovaries and said there was a cyst, it does not mean that you have PCOS. So what happens every single month is that the pituitary gland in the brain will send out some hormones to stimulate the ovarian follicles. It will make a couple of cysts. One of them will become a dominant follicle, which will ovulate. If it doesn't get fertilized and implant, then it starts the menstrual cycle. Now, with polycystic ovarian syndrome, there's really kind of 3 diagnostic criteria, and you need 2 out of the 3 to technically make the diagnosis. So the first one is what we call oligomenorrhea or amenorrhea. And this means absence of the menstrual cycle, missing periods, going multiple months without periods, or some of these patients just don't have periods at all. And that's because they're not ovulating. So what's happening is this insulin resistance at the level of the ovary is driving up the androgens, it's driving up the estrogen levels. With the lack of ovulation, there's a lack of progesterone relative to estrogen and testosterone. And that causes a lot of ramifications that we can get into, but you have to be missing periods or having no periods at all. The second criteria is just what we touched on, hyperandrogenism. Now, this can be diagnosed clinically or it can be diagnosed biochemically with labs. So clinically, we might see that the patient is developing some acne issues, cystic acne, related to more sebum and oil gland production from the testosterone. They might have dark hair growth patterns, and it's typically dark facial hairs. It may be around the nipples. It may be down onto the abdomen and stomach. And then the pubic hair distribution may be more robust or down onto the legs. So there's some clinical criteria where we can kind of grade that, give it a number. But you could have clinical signs of hyperandrogenism. Another one too is like male pattern baldness. So the high androgen levels can cause thinning of the hair. They can cause thinning at the temples here. So that's another thing that we can see in more severe cases. The other way is we could do a lab test. So we could draw the labs and see that the DHEA or the testosterone is elevated on the labs, and that would be the second diagnostic criteria. The third one is polycystic ovaries. And like I said, it doesn't mean that you have cysts on your ovaries. The polycystic ovary on an ultrasound looks very, in a very specific fashion. It has these tiny little follicles that surround the outside of the ovary. And sometimes the radiologic sign will be like string of pearls. So it looks kind of like a pearl necklace around the outside of the ovary. And that's because you have a ton of these tiny little follicles that are never getting stimulated. They're never developing into that ovulatory follicle. And that would be the third criteria. So if you see your doctor, they've done some lab tests, they've done an ultrasound, you really need all of those things. We can be highly suspicious of PCOS. And I see a lot of patients get told they have PCOS when I might work them up, and I really actually don't think it's PCOS. It might just be peripheral insulin resistance, inflammation, other lifestyle factors at play. So sometimes I do think, it's overdiagnosed or over self-diagnosed sometimes. And it doesn't really make a difference, in the long run. If the patient's missing periods and can't get pregnant, then you got to figure out how to fix that. But that's kind of the basic diagnostic criteria for PCOS.
And so how can the PCOS actually affect fertility?
Yeah. So the reason that patients with polycystic ovarian syndrome cannot get pregnant, first is they're not ovulating. So we call this anovulation. They're not releasing an egg. And if you can't release an egg, it cannot get fertilized by the sperm, and it cannot implant and grow a human. So that's part of it. The second reason is they may have intermittent ovulation, but they have poor progesterone production from the ovaries. They may have an inflammatory state due to the high blood sugars and the dysregulation of the hormones. There's more oxidative stress, more inflammation. So even if they would release an egg, there's an inflammatory state within the endometrial lining. And may have poor implantation or risk of miscarriage. But the general reason why most PCOS patients can't get pregnant is lack of ovulation. And that's where drugs like Clomid, or clomiphene citrate, or we're now using another one called letrozole or Femara. These medications increase pituitary secretion of FSH and LH, which is abnormal in PCOS patients. So these patients tend to have an abnormal ratio of FSH and LH. The luteinizing hormone, that's what LH stands for. The luteinizing hormone tends to be higher, sometimes higher than the FSH. And by giving these oral medications, it's basically secreting a robust amount of the follicle stimulating hormone, trying to overcome that high LH level and actually develop a follicle for ovulation. And it can be helpful for helping these patients get pregnant. But if you're not implementing these other lifestyle factors, if you were to get that patient pregnant, depending on her baseline metabolic health, she's still at a lot of increased risk during her pregnancy for things like gestational diabetes and preeclampsia. And then long-term, we know PCOS patients are at an increased risk for all cardiovascular disease and diabetes, high blood pressure, everything that includes metabolic syndrome.
Okay. So, and I did take Clomid with my second pregnancy, and I just trusted the doctor. I didn't really even ask what the risks were back then because I was not very smart about things. What are the risks of taking these medications?
Yeah. So all in all, they really don't come with serious risks or side effects. They work similarly but differently when we talk about letrozole versus clomiphene citrate. Now, the studies would suggest actually in PCOS patients that letrozole is better because these patients tend to have higher levels of what we call anti-Müllerian hormone. They have a ton of these small follicles, and they're very prone to hyperstimulation of the ovary. So sometimes these medications actually can work too well. One of the risks of using ovarian stimulation is multiple pregnancies. So you can actually release more than one egg. So there's an increased risk of twins. or even sometimes when these patients are treated by the reproductive endocrinologist with either oral medications or injectable gonadotropins, they sometimes will have to abort the cycle because there's so many eggs that the patient could get pregnant with twins or triplets or quadruplets or something like that. And that's may sound like a good thing, but it's an extremely risky situation. And so these patients have to be cautious of that the ovarian stimulation is being monitored, that we're looking at the ovaries to see what the follicle development looks like. Now, there's some also subtle physiologic changes that happen with the endometrial lining, cervical mucus, and things like that with these medications. But generally, if you start at the lowest dose and titrate up slowly based on the response, they generally don't come with, a lot of side effects. And you're really only using them for about 5 days during the menstrual cycle. So we typically will give them, every doctor will have a different protocol, but they're typically given cycle days 3 through 7 or 5 through 9 or somewhere kind of in that window, because that is the follicular phase. That's when your body is supposed to be recruiting the follicles, developing the follicles. And so you give them at that specific part of the cycle to try to get an egg to ovulate.
I want to dive a little deeper into gestational diabetes. Is this something that PCOS patients have a higher risk of than the normal population? And what is it about pregnancy that causes insulin resistance to rise during that period of time?
Yeah, so one of the pathophysiologies of PCOS is that these patients have insulin resistance, especially at the level of the ovary. Not all of them have peripheral insulin resistance, but because we have insulin sensitivity in all of our different tissues, so in the muscle, in the fat, in the liver, in the ovaries. But the problem is that PCOS patients are at an increased risk of developing gestational diabetes, which is a disease of insulin resistance. Now, pregnancy is an interesting thing because this is the one time in our life where we develop physiologic insulin resistance. So let me kind of break this down. When you get pregnant in the first trimester of pregnancy, your pancreas starts increasing insulin production by about 30%. So it starts putting out more insulin into the body. Some of these patients are already coming into pregnancy, what we call hyperinsulinemic. They're already making a ton of insulin in an attempt to make the blood sugars normal. And so now this may exacerbate the hyperinsulinemia. Now, in the first trimester, though, the insulin sensitivity tends to be better. It's more of an anabolic state for the body. It's trying to grow its storage of energy for this growing baby. And then as we transition into the second and the third trimester, as this placenta starts to develop, there's a lot of other hormones that are involved with growing a pregnancy. So not only robust amounts of estrogen and progesterone, but we start to see HCG rise. We see something called human placental lactogen. So there's some hormonal changes that happen, that the placenta is secreting hormones that increase physiologic insulin resistance. And so the question would be is, why would you want to develop insulin resistance in pregnancy? A lot of this is the way that the body shunts energy to the baby. So as the pregnancy progresses, we want a large amount of glucose and fatty acids available to cross the placenta to go to fetal use for the fuel. I mean, you can imagine the metabolic requirements of literally growing a human inside someone's belly. It requires a lot of fuel. And so these physiologic changes in the hormones basically assure that there is a free flow of tons of energy, free fatty acids and glucose. Now, the problem is this could come with ramifications for the mother. And that's why we test for gestational diabetes. The caveat here with gestational diabetes is we have cutoffs for glucose levels to diagnose it. It can be done with a 1-hour glucose tolerance challenge. It can be done with a 3-hour test, or sometimes these patients actually have prediabetes or even type 2 diabetes that's been undiagnosed. So you can check things like a hemoglobin A1C. The trouble in pregnancy is it's falsely lowered due to the rapid turnover of red blood cells in pregnancy. But some of these patients, if these tests are done in the first trimester of pregnancy, that's actually prediabetes or type 2 diabetes. That's not gestational. Gestational is diagnosed at generally 24 to 28 weeks of gestation as we're nearing that third trimester. But the other thing I really wanted to hit on here is that even if a person has normal blood glucose levels in pregnancy, let's say they pass the glucose test, let's say they're even checking their blood sugars in pregnancy and they have normal glucose levels. The question we always have to ask in the back of our mind is at the cost of what amount of insulin? Because we know that pregnancy is a hyperinsulinemic state. And so if you have even more insulin that's being secreted, to make the blood sugars normal. The baby's at risk, the mom's at risk. She's at risk for high blood pressure, for preeclampsia. And the baby long term in pregnancy, there's something called fetal programming or epigenetic changes that happen. So literally, the way that the mom eats, the stressors and things that she's exposed to can actually modify the DNA, kind of turn off light switches on and off. That's kind of how I like to paint that picture a little bit, because it's sometimes hard to understand how you could alter your baby's DNA, but it's basically kind of turning these light switches on and off. And we know that patients with hyperinsulinemia and hyperglycemia in pregnancy, their babies are at an increased risk for obesity, type 2 diabetes, cardiovascular disease over their lifetime. So even if you make it through the pregnancy safely and the glucose levels look normal, there could still be changes related to hyperinsulinemia that could be affecting, the baby and the offspring of that mother. So it's super important that these are controlled during pregnancy.
What I found in my research over the last 2 years with the spike protein infiltrating itself into all of us is that there's this effect on insulin and more of an exaggerated response of insulin in making some people go hypoglycemic because of it. And so I'm wondering if this is connected to the rise in infertility as well as the other issues related, and the rise in PCOS over the last 2 years because of this overshot of insulin and its relation to, growing a fetus.
Yeah. It's hard to say because a lot of these things are multifactorial. So we like to really focus on diet and nutrition when it comes to insulin resistance, but there's a lot of other factors at play. There's endocrine disruption from chemicals. There, is a lack of sleep. We're getting way too much blue light, not enough sunlight. From an exercise perspective, women are really overprescribed cardio and are not encouraged to do a lot of resistance training. So they tend to carry less muscle mass than they probably should. There's so many factors involved with insulin resistance. For instance, just lack of sleep or things like mouth breathing instead of nasal breathing can change the oral microbiome, and certain pathogenic bacteria in the mouth will inhibit nitric oxide production and increase insulin resistance. So there's so many factors when it comes to insulin resistance and PCOS and infertility that are just outside of even the little wagon wheel that we stay in sometimes when talking about just nutrition. There's so many other factors that impact it.
It's true. It's not just the food and cutting out the sugar, but there's all of these other things. And I love that you promote strength training for women because muscle is beautiful, but muscle is so metabolically healthy with the healthy mitochondria and the energy. And all, we could do a whole podcast on that. I want to touch on the thyroid's relationship to, because you were hypothyroid, I was as well. I was insulin resistant, you were as well, but where does the thyroid specifically come into play with fertility and PCOS?
Yeah, so the most common cause worldwide of hypothyroidism is iodine deficiency, but in the US, that's not always the most common cause. The more common cause is autoimmune thyroid dysfunction. So patients that get Hashimoto's or develop autoantibodies against the thyroid gland. Now, insulin resistance isn't, the one that most people think of when it comes to hypothyroidism, but insulin resistance can cause hypothyroidism. And that's because we have estrogen receptors within our thyroid. And we have other protein binding globulins within the blood that can be off with PCOS, and these binding proteins can bind our thyroid hormone and lower free thyroid hormone levels. There's also a lot of nutrients besides iodine that are required for proper thyroid production. So zinc, selenium, magnesium, vitamin C and E, B vitamins. There's so many other nutrients that are required. And so if you're eating a poor nutrient dense diet, if you have insulin resistance, there could be, once again, a lot of pathways to the same problem. And it usually is multifactorial. The good news is that if you have hypothyroidism related to insulin resistance or prediabetes, that's more reversible by repleting the nutrients, fixing the glucose issue, fixing the insulin issue. And a lot of times we can restore normal thyroid function in these patients. If a patient has autoimmune thyroiditis, that's more of a chronic issue because it's harder to, there's no quote unquote cure for that, but you certainly can try to decrease the inflammatory burden and keep the autoantibodies as low as possible through lifestyle. but depending on how long a patient has been developing that. And women are more at risk for autoimmune thyroid dysfunction because in pregnancy, our blood mixes with our baby's blood. This happens in a small amount at the placental interface. And so basically, we have free floating DNA. It's called cell-free fetal DNA that circulates within the maternal bloodstream. And it is interacting with our immune system. And pregnancy is generally an immunosuppressed state, but just the presence of these small amounts of fetal DNA can trigger an autoimmune reaction in moms. Poor gut barrier lining, poor oral microbiome. There's lots of other ways that this event is incited, but women are more prone to autoimmune thyroid dysfunction for that reason.
And then they keep the autoimmune after the pregnancy is over, correct?
Yeah, I mean, we don't know a cure, but I have seen patients keep their antibody levels very low. I have seen patients have the antibody levels return, back to normal levels. But yes, chronically, this is an issue that if in any inflammatory state, these autoantibodies could rear their head and, spike really high and start attacking the thyroid gland. And long term, the longer that thyroid gland gets attacked, it could destroy the normal tissue, requiring a patient to be on lifelong thyroid replacement therapy.
If anyone is a listener of mine, they know that my Acceleradine iodine is my number one supplement for everybody, including pregnant women and young children. And because it helps the endocrine system, it helps with the estrogen production, and it helps obviously feed the thyroid. What diet? Obviously, diet is huge with what you are telling your patients with PCOS. What is the diet that you recommend for your PCOS patients?
When you look at the literature, the Mediterranean diet gets a lot of, play in the literature. And really, like I said, any diet that calorically restricts a patient to drop weight to a more normal level, a lot of times will help. But when we think about long-term preventing a lot of the risks with PCOS, cardiovascular disease, diabetes, these types of things, low carb or ketogenic diets can be extremely helpful because the baseline insulin resistance. There are studies in PCOS on the ketogenic diet, and they show remarkable results. They show that the patients return to normal glucose levels. They can correct the hyperinsulinemia. They restore the FSH to LH ratio. They restore ovulation. And that is super important. Now, it's not a 30-day program. It's not a 60-day program. You might be able to do that to get pregnant, but this is something you're dealing with chronically. Now, does it mean that these patients have to be on a ketogenic diet for the rest of their life? Probably not. For me, I started with therapeutic ketosis, and now I live more of a low carb diet. So I always tell my patients, nobody developed diabetes from eating blueberries and carrots. So, really sticking to whole foods, nutrient-dense animal foods, healthy proteins, good fats in the diet is super important. But unfortunately, our diets are so high in processed carbohydrates. I mean, we didn't have a carb problem because of, people eating quinoa and blueberries and carrots and potatoes and things like that. It's the amount of added flours, added sugars, added food additives in general, food dyes, vegetable oils, which is basically found in all processed foods. So if you can just eat a whole food diet, my rule is, did it have a mother or did it grow in the ground? You're probably going to be doing pretty good. But for therapeutic ketosis, for patients in the studies on ketogenic diet with PCOS, the patients were eating less than 30 grams of carbs per day. And that essentially assures that the body is going to be using fat oxidation and ketone production as a fuel source as opposed to primarily relying on glucose.
That's where my protocols come in, is more real food. 62% of the diet that Americans are eating is processed food, and it's killing the liver. It's causing fatty liver disease that was non-existent unless you are an alcoholic. And now we're finding it in children because their diets are 67% processed foods, and then it's taken out all of the the fiber out of the foods. And even when you go to Whole Foods or the natural market and you look at the organic soups, they've got canola oil in them. So then you've got the seed oils so anything that's not packaged and just like you said, comes from the ground or an animal and has a mother. I love my wild animal protein. I fill in with my vegetables, and I tell people to fill in with the fat according to their weight loss or weight gain goals and find what feels right for them. And of course, make sure that you're tending to your leaky gut if you've got that issue as well. Let's talk about exercise, because you and I both are athletes, or we were, and I still consider myself one, even though everyone says I'm just a mom at 47, likes to work out. But I could get away with working out extreme chronic cardio when I was in high school. My girls are rowers. They row for 3 hours a day. They're training for nationals. That's not going to last. And I remember when I was doing that in high school, I lost my period. So I never thought that I had PCOS because I was not getting my period because I was overworking out. And that was the reason. So it kind of put away the fact that there was any sign of PCOS, because I was just assumed that I was working out too much for my sport. That was causing the amenorrhea. Thank goodness my daughters have regular cycles, so that's not an issue. But fast forward as we get older, it's, us women have a hard time not doing the chronic cardio because that's what we've been told we're supposed to do. Where does it come in where exercise is too much, but we need it? Where does strength training fit in, HIIT training? Let's walk through exercise and the importance of it in supporting PCOS.
So movement in general, all movement is good movement. We live in a very sedentary society. We're seated in chairs all day. We're at computers. We're just not walking around. We don't even have to hunt for our food. We can pick up our phone and get Uber Eats delivered to the house. So we're just generally more sedentary. So more movement is always a good thing. There is data behind 10,000 steps a day. Okay. Just wearing a pedometer and walking 10,000 steps. When it comes to actual focused exercise, right? We have cardiovascular training on one side. We've got resistance training on one side, but let's be real. Resistance training, you're also working the cardiovascular system. So when you do cardio exercise, there definitely are benefits. There's benefits to zone 2 training. There's benefits to your heart, getting the blood pumping. There is a change in the fuels that we burn depending on if we're doing low intensity steady state. So that would be just like walking. So just walking at baseline, you're doing fat oxidation. So, go walk a couple miles. Now, cardio, women are really prescribed cardio. In my town, you've got F45 and Orange Theory and all these places and these circuits and these HIIT training. And like I said, all exercise is great. But from a body composition standpoint, you can't outrun a bad diet. I tried to do that for multiple years. I signed up for some half marathons thinking that if I just ran a bunch of miles per day, that my body would look great. And it didn't. And I still had problems with my blood sugars. That's because long bouts of exercise can really ramp up cortisol. And sometimes we are stressed from other things, from our jobs. We're stressed from lack of sleep. And we have adrenal issues. We're just in this constant state of sympathetic overdrive, and we never have time to kind of rest and recover and nurture our parasympathetic system. So you absolutely can overexercise. In athletes, you can overexercise to the point of dropping body fat really low and lowering estrogen. And that can be another reason why some athletes lose their periods. They just get too lean. But when it comes to resistance training, I think that's where the bang for your buck is. If you are busy like me, you're mom of 3, you got a job, you only have 20 or 30 minutes to spend in the gym, resistance training is going to benefit you more long-term. And that's because cardio doesn't really stimulate our lean body mass. It doesn't stimulate this growth hormone and testosterone response, this anabolic response to maintaining our lean tissue. And you had mentioned this earlier, muscle isn't really just for strength and locomotion. It's not just for moving our skeleton around the world or lifting up heavy things. It's an endocrine organ. So when you exercise, when you resistance train, it secretes myokines, literally chemical messengers that talk to the other organs in your body. And what happens particularly for women is, we are very resilient when we're in our 20s. We're in college. We can get away with kind of bad diets and only training here and there. And actually little kids like my girls, they can get an anabolic response from protein at about 10 to 15 grams of protein. That's not that much. As we age, we need 20, 30, 40. As you get older, maybe even 40 or 50 grams of protein at the first meal and last meal of the day to stimulate that lean tissue. But the best way is to lift some things to stimulate that tissue. I tell patients, it's like you need to tell your body that you still need your bicep. You need to use that muscle. And so resistance training is so important because as we go through menopause, as we lose our hormone production and go through menopause, lean body mass is the one thing that can really protect our metabolism. It can really protect our risk of insulin resistance, and it reduces the risk of things like falls as we age. Everybody can imagine their grandma or grandpa right now with kind of that short shuffling gait because they've lost their fast twitch muscle fibers and they've lost their strength and stamina. So we've got to resistance train in our younger years and build up this lean body mass, and not just strong muscle, but strong bones too.
I love that you mentioned protein. I laugh when I go out to lunch or dinner with some girlfriends and they're having their wine and a small salad with no protein on it and skimping on the protein. And as you get older, you actually need more protein. So can you talk about, number one, intermittent fasting as it relates to PCOS and how much protein women should be targeting?
So intermittent fasting is a great tool, but it's just a tool. And we know that there, are studies where they've looked at like alternate day fasting, intermittent fasting. And when we go through a period of time where we're not eating, we don't secrete insulin, we lower our blood sugars. So this can be a good tool, regardless of what's happening with your diet, to restore some of these things. Now, it can be overdone. I've seen patients that are just obsessed with the fasting and they're doing tons of fasting. They're doing multiple day fasts. And that's okay intermittently, but chronically, if you're doing lots of extended fasting, you're not getting nutrition. You're not getting nutrients. You're not getting protein. And you can always have too much of a good thing. You can over-exercise. You can over-fast. When it comes to, what was the second part of the question? You said fasting and
Protein. So
protein. Yes.
How much protein are you recommending?
So women are chronically under eating protein, and not necessarily just under eating the amount of protein they eat in a day, but they're constantly getting what we call sub-threshold amounts of protein. So like I had mentioned, for a younger kid, like one of my girls, they can get this anabolic response, this kind of message from the body, to maintain lean body mass through a smaller amount, maybe 10, 15 grams. As we age, we need more. And this means all at one meal. Protein, this anabolic response is protein ingested all at once. So it's not sipping on a protein shake for multiple hours. It's slamming it down all at one time. So the most important part is the first meal of the day and the last meal of the day. And it really should be 30 to 40 grams of protein. Now that might sound like a lot for some people, but ideally, it's a whole food protein. So chicken, beef, salmon, shrimp, eggs, cottage cheese, yogurts. There's lots of ways to achieve this amount. You can use protein supplementation, and whey proteins, but it's really better to fill the gaps and not to be used as the primary source. But when we look at body composition in people who want a good body composition, you could be eating upwards of 0.8 to 1 gram per pound of body weight. So for a 150-pound woman, that's like 120 to 150 grams of protein per day divided up into, about 3 meals. You're talking 40 to 50 grams 3 times a day. As we age, as we get inflamed, if we get something like cancer, if we become elderly and our gastric pH drops, we actually need more. So grandma might need more than granddaughter at the Thanksgiving table. And that's really something that's hard for people to wrap their mind around, because protein is that one macronutrient that you really have to make a concerted effort to find. Processed foods basically contain carbs and fat. They're very easy to find. It's very easy, right? Carbs, you've got pretzels and goldfish, you've got fruit, you've got candy bars, rice, pasta, you name it. Fats are easy. You've got butter and this and that. But proteins, when you're talking about beef, chicken, fish, if those things aren't prepared, ahead of time, people have trouble finding protein sources in the diet. And processed foods are low in protein. They all are.
It's so funny as you're talking. I'm thinking about my grandma who would sit down to this small little, take like 2 bites of the protein, and everyone else, the young kids are the ones that eat without thinking about it and just actually end up eating more. I love my protein. I also love the fact that you can't binge on protein. I'm not going to have 3 ribeye steaks in a row, but you give me the Pringles and the pizza, that's a different story. And that's a whole nother podcast. Before we go, I want
But
to
you're
make
right.
sure.
But you're right, though. Protein and fat are more naturally satiating. And there is a theory that our body will continue to look for more food until you give it that level of protein. So, because women are chronically eating subthreshold amounts of protein, we're hungry a lot and we're looking for snacks when we get bored because we're never giving our body what it actually needs. And the same goes for kids. It's why the kids are like little snack monsters in the summer because they're never getting that protein meal.
And that's why with my kids, I always say protein first, and then we'll talk about the rest. Before we go, tell us about the Hard to Kill Academy and your book.
Yeah, so I wrote a book last year called Hard to Kill, and it centers around what I believe are the foundational principles for health. It's a story about how I went through this journey and kind of figured it out on my own. I might be a doctor, but I'm a human too. I'm a patient, and I struggle with all the same problems with my patients too. So it's written in a way that my 12-year-old daughter could understand, but it goes through the 5 pillars that I believe kind of set that foundation. And that's what we eat, how we move, how we sleep, how we create stress resiliency, and then kind of our environment, which is the people, places, and things in our life. But there's an online academy that is a companion to that book, which provides community. So I've got a private Facebook group. You also get quarterly Q&A calls with me, which is pretty much the only way to get me one-on-one doing Q&As these days. And it has a whole video library that dives deeper into the topics that are within the book to help people live a better life and be harder to kill. It's almost self-explanatory. Medicine is not coming to save anybody. We have got to start taking self-accountability for these things. And you got to educate yourself because there's a lot of information out there and it can be really overwhelming. But this is like the simple things. Like if you're not doing the simple foundational things, you're getting down a lot of rabbit holes on the internet, that aren't going to help you if you're not doing the foundation.
I love everything about you. The fact that you've got your medical degree, you're a mom of 3, you're a wife, you are a business owner, you are doing all the things. You've had your own experience. You just offer so much to women in this complete package, and that's why I love following you. I love everything you're doing. Where can people find you on social media and your website?
Yeah, I'm most active on Instagram, but I've got Facebook too, at Dr. Fit and Fabulous, and it's spelled out DOCTOR. My website is drfitandfabulous.com. That's where you can find links to my podcast, to the academy, to the book, and all that other information.
Wonderful. Thank you so much, Jaime. I love everything you're doing, and we might just have to have you come back on because you're a wealth of knowledge. And before we go, I just wanted to touch on 2 supplements that I know help with PCOS and with hormonal balance. And I mentioned one was the Acceleradyne iodine. It regulates estrogen production, obviously helps with your thyroid. It has 100% bioavailability and enhanced with scalar frequencies to detox the cells of heavy metals and radiation, but it cleans the blood for the liver to do its job to detox the excess bad estrogens that lead to hormonal imbalances like PCOS and PMS. And it also helps with blood sugar regulation. It reduces inflammation, fights oxidative stress, triggers apoptosis, which is the death of weak and unhealthy cells. And during pregnancy and when you're going through puberty are the 2 highest times that you are actually experiencing apoptosis. So it's really important. And it helps clean up the body and promote balanced hormones. The second one is the accelerated keto. So as Jaime was talking about getting yourself into a low carb, more ketogenic state and lowering the insulin and blood sugar, it's super important for hormonal balance and fertility. The accelerated keto is suppressing the appetite. It kicks you into ketosis within 30 minutes, helps with intermittent fasting, but then supports you on that low carb diet. Does not need to be a high fat diet. It is, you fill in the fat with what works for you, but it helps with reducing inflammation throughout the body, helping with the female hormones, stabilizing blood sugar, and of course, elevating mood, all of the things that us women need, and our husbands and partners will appreciate that as well, right? So those two are a no-brainer for anyone experiencing PCOS. If I had known about them when I was experiencing infertility, it would have been a game changer for me. Thanks for joining me today. And if I can help you with your health issues, you can contact me directly through the website, SaraBantaHealth.com. Happy to put together a protocol for you. Did you learn anything today? Do you have PCOS? Leave a comment below and let us know. Let Jamie and I know what you learned from today, what you're experiencing, and what has your fertility issues and your fertility experience been as well. Join the free group coaching on Telegram with the link below. Teach you on a daily basis with tips and tools to enhance your health, and you will be a part of a like-minded group to support you on your journey, in addition to truly taking control of your health. The protocols and supplements I always discuss on my podcast are found at SaraBantaHealth.com. You can follow me on Facebook and Instagram under Accelerated Health Products, and across over 100 channels under Accelerated Health TV and radio show. If you like what you hear today, please hit the subscribe button and share with a few of your friends who may need my help. And you can join us every Monday and Tuesdays for new podcasts, and use coupon WELCOME10 for 10% off site-wide. Thanks again for joining us here, and have a great week.